Chapter 22, Diabetic Emergencies and Altered Mental Status. Start off with the pathophysiology of how we get patients in these conditions. So normal consciousness regulated by the reticular activating system, or the RAS, keeps you awake, keeps you paying attention, helps you stay asleep. Our normal operating functions are based in here. Oxygen perfuses the brain, keeps it functioning normal. Glucose provides that energy to the brain, and then water has to be there to maintain the hydration. So those three things are required for normal mental status, and if we have a disruption, we're going to have problems. So if you have hypoxia, hypoglycemia, or dehydration, things won't be working right with the reticular activating system. Altered mental status could be from trauma, infection, chemical toxins, something that interferes with how the brain receives the nutrients and the oxygen. Could be a brain something damaging the brain itself, the brain structure, or it could be other body parts that are causing changes in the homeostasis. Maybe the pancreas is not producing enough insulin. Maybe the kidneys are taking out too much water, retaining too much water. So what we need to understand is it could be just a mental status change, or it could be a problem with another body system that we need to address. So when we're assessing the altered mental status patient, very important that we maintain our safety. Um, they are not aggressive. Well, they are not intentionally aggressive, but they can be confused. So always have your guard up. Be aware of what's going on around you. Call law enforcement, but also know that law enforcement will uh, escalate things sometimes. So in Colorado Springs, we have the Community Response Team, CRTs. It's a paramedic, a nurse practitioner with mental health background, and a law enforcement officer. So they work really good together. They will help you with these altered mental status patients, the psych patients, the ones that we're not sure what's going on, and they can give you the best of everything. But they're a limited resource, so they're not always there. So we need to be aware of how to do it and how to protect ourselves as we go along. So primary assessment, airway, breathing, circulation. As you're getting the altered mental status established, you're talking to your patient. That's going to be maintaining your airway and breathing. That makes sure you know what's going on. Make sure they have the ability to maintain their own airway and that they can breathe adequately. Maybe it's the breathing that is causing the altered mental status. Maybe it's an oxygen issue. So get a pulse ox, look at the patient, look at, are they blue in the face, what's going on to help you out with that airway, breathing, circulation. Look for hypoperfusion. Remember, anxiety is one of our first signs of hypoperfusion, so there's your altered mental status. So get your AVPU, document a baseline mental status so you know they're responsive to verbal stimuli with inappropriate words. You are responsive with incomprehensible words. They're responsive with a gaze towards the patient, to the responder. Difficulty with people that have challenges or kids, because you don't know what their baseline is. So you're going to have to kind of work within the system, try to figure out what you've got, ask the caregivers. If it's a child, mom can tell you what each cry means. They have different cries for different things, and mom will know exactly what it is. Sometimes the subtle changes are indications there's something else going on. I had a friend of mine that had a basilar skull fracture, and we really didn't notice it until she started asking the same question over and over. You'd have a conversation. It's like, where are we going? We're going to Joe's. Oh, that sounds fun. 2 minutes later, hey, where are we going? We're going to Joe's. Oh, that sounds fun. And 3 or 4 minutes later, hey, where are we going tonight? We're going to Joe's. So little subtle changes. try to get a good history, try to figure out what might happen to them. Interview family members, bystanders, get a baseline for them. Look for medications, medical alert bracelet, anything, any clue that can tell you what might be wrong. Document the level of consciousness. And this is where we got a tool called the Glasgow Coma Scale. I'll link a video to that in the supplemental videos for Chapter 3 or Module 3. The Glasgow Coma Scale is your foundation for identifying where the mental status is at what time of your treatment. So let's talk about diabetes. The body needs sugar in the form of glucose to function. It's our energy. Everything we take in is broken down in the basic building block of glucose. That's what floats around in the body. The cells have to have it to stay alive. The only way to get it into the cells is through insulin. Insulin opens the door and helps get it through the small hole to get it into the cell. Pancreas gives out pushes out insulin every time the glucose gets over 90 milligrams per deciliter. It goes out, finds the glucose, and then escorts it into the cell. It's kind of like that really cute girl that you take to the club and you get in because the bouncer says we need more cute girls, and you're just along as the big old guy. So gets you into the party. We have to have a normal glucose level to function. If it gets too high or too low, that starts to cause problems for us. So here's kind of an illustration of the pancreas dropping the insulin into the blood vessels. It attaches up with the blood sugar and helps you get into the cells. Diabetics, we have a couple different levels of diabetes. The type 1 does not produce insulin. That's an early onset, like childhood onset. The pancreas does not just doesn't produce the insulin it should. Type 2, as the body grows older, maybe the pancreas doesn't produce enough insulin, or the body has got used to the insulin and it's not using it efficiently. So a couple things going on here. Those are the type 2. So type 1 is early onset with child, and then the type 2 is older in life. The islets of Langerhans in the pancreas produce the hormone insulin. So you got that insulin floating around, helping the molecules of glucose into the body or into the cells. So it's very important as we're going through life to have enough insulin to make sure we get that equal balance. Diabetes mellitus is over or underproduction of insulin, or the inability of the cells to use the insulin properly. So here we've got the type 1, that's the insulin dependent. They have to take insulin. They've got either the insulin pump, they do injections, or they've got the stick-on insulin pumps that the newest ones out there. Type 2, formerly called non-insulin dependent. Type 2, a lot of them use insulin anyway. The body is not using the insulin that's in there correctly, so we add to it. Most of these are controlled with diet, oral anti-diabetics like metformin, and sometimes insulin. Hypoglycemia is low blood sugar. Hypoglycemia. Either you took too much insulin and you used up all your glucose, or you didn't eat enough. You took your insulin and you forgot to eat, or you didn't get to eat, and now you've got an imbalance here. Over-exercising or exertion. You did plan on going for a 2-mile run while the cops chased you, and you didn't eat enough, and your body used up all the glucose you had. Maybe you're sick and you've been vomiting. You've lost the nutrients that you had in your digestive system. So something has messed up your metabolic rate, your food intake, and the blood sugar drops. As the blood sugar drops, your brain needs more sugar, so your cells start to starve. The lack of sugar starts to create an altered mental status process. You become unresponsive, or you can even have permanent brain damage. So it's important to recognize the symptoms as they come on. This is a rapid onset. It's not one that goes out over days. They have abnormal behavior. Sometimes they appear drunk, which can get confusing because you have a patient who looks like they're a DUI patient, and then you check a blood sugar and they're way low. They're pale, sweaty skin, tachycardia, rapid breathing, seizure activities because the brain doesn't have the glucose to function. It's important that we get sugar in these patients as quick as possible. If we can, if they are capable of protecting their own airway, we give them more glucose, fix them a sandwich, give them a Coke with extra sugar, give them a good sweet tea, something to bring that sugar level back up. Then we start to have to find out why they have this problem, because we got to sustain that sugar load as they heal. So you got to figure out if they were overdosed on their insulin, maybe they didn't eat as much as they should, or they're sick. Something's going on to change their blood glucose to a dangerously low level. Hyperglycemia, the body can't either doesn't produce enough insulin, they forgot to take their insulin, or they overate. Uh, Buffets in Vegas, commonplace for hyperglycemia. Could be infection, stress. Stress causes a problem with your blood sugar. Or like I said, they went to the buffet. It takes days or weeks to get to this point. It's not something that they just wake up and 10 minutes later they have hyperglycemia. They get it over a period of time. They'll have chronic thirst and they'll still be hungry. They've got too much sugar in their bloodstream, but they're hungry because the sugar is in their bloodstream and not their cells. So their cells are sending the signal to the brain, hey, I need some sugar, what's up? And all this sugar's out there in the bloodstream taking up space. And so it's because it's a bigger molecule, it's drawing fluid into the vascular system. So you get all this extra fluid in there, so it makes you thirsty because you're basically dehydrating your interstitial tissue. Your kidneys see all this extra fluid, so you start urinating a bunch. You're nauseated because you got all the extra fluid going on. And even though you've got increased thirst, increased urination, you're dehydrated because the cells don't have the water because it's all going to the intercellular. The starving cells start to burn fat and proteins in a way that produces excess waste. So now we've got that lactic acid being produced and put into the system. Eventually we get to a problem called diabetic ketoacidosis, or DKA. That is a serious medical condition for the hyperglycemia. Not everybody gets to this point from hyperglycemia. It's one of those that it takes time, but once we get there, it's a true medical emergency. They will be shocky. They will have low blood pressures, signs of hypoperfusion, rapid breathing, and when you smell their breaths, it kind of smells fruity or acetone in because of the ketones that it's releasing. So it's something to kind of note there. They'll have a funny odor to their breath. Anytime we're dealing with a diabetic patient, be aware of your safety. Because of the change in their mental status, they could become violent real quick. They don't know what they're doing. They just get aggressive. So be aware. Maybe send the new guy in first. Perform your primary assessment. Make sure they can protect their airway. And then get all the history you can, being careful to get a past medical history, current history of last oral intake, last medications, making sure they're taking their meds like they're prescribed, and get a good understanding of what's going on with their mental status and their physical status. How long has this been going on? When did it start? What's it been like while they're progressing through here? Anything extra going on? Any injuries? Any interruptions in the episode? Maybe they got better and then now they're worse. Have they had any seizures? Gives you a history of whether there might be a cause of the seizure caused the diabetic emergency, or the diabetic emergency caused the seizure, or if they've been sick and they've got a fever. Get a good sample history. Look for ID bracelets, wallet cards, cards on the refrigerator, anything that can give you a clue. Check for their medications. Look in the refrigerator. That's where they typically keep insulin, as it needs to be stored in a refrigerated environment. Check for the glucose meter. Glucometer typically means they have diabetes. Look for implanted insulin pumps. They go, usually looks like a little pager, hooks onto the waist, and it's got a tube that goes into a transdermal inducer that's on the side of the body. Maybe it's the smaller pumps that go on the shoulder, on the across the belly. All kinds of options for those, but ask. And if you find something, ask more questions. As EMTs in our system, you can do a blood glucose monitor, really simple, and we'll go over that to teach you how to do that. When you're doing your assessment, make sure they can swallow. If they can, now you've got some options to treat them. So get the baseline vitals, get a glucose meter reading, try to figure out if they're having the low sugar or high sugar. Rapid onset, usually low sugar. Intoxicative appearance, both. Cold, clammy skin, usually hypoglycemia. Elevated heart rate and hunger, usually hypoglycemia. Uncharacteristic behavior, they're not acting normal. They're anxious, they're combative, they're having seizures. If you think they can swallow and you're confident they can protect their own airway, then you have some options with the oral glucose. Get a blood level reading real quick. Find out where they are. Maybe they've just recently taken one. Ask them if somebody's done it. The book says you probably shouldn't use their glucose monitor. If you've got one and they've used it recently, it might be good to compare it, or you might want to use your own just to get a contrasting reading. So there's some pros and cons of both sides. In the glucose meter, you've got a meter. This is the meter right here. To turn it on, you take a strip from here and push it in. It automatically comes on and says apply a drop of blood. These are the lancettes. You put them next to the finger, you push it, it squeezes a needle and goes out and pokes the finger. If they're a diabetic, they do this multiple times a day. They know exactly what you're doing and why you're doing it. You've got alcohol preps to clean the skin before you poke a hole in it so you don't get infections. Once you get a drop of blood, you drop the tip of the meter stick into that blood. It sucks up enough for a reading, and then it'll give you a reading out up here. If it says low or high, that means it's outside of the range that it can read on its own. So low and high, you don't have any treatments. Low, you definitely have it. So less than 60 is symptomatic hypoglycemia. Less than 50 will probably have altered mental status. Greater than 140 is hyperglycemia. Greater than 300, you're going to start seeing those DKA symptoms. If you have a reading that doesn't make sense, such as it shows a blood sugar of 20, but the patient is alert and talking to you, that's a time to question the reading. Check the expiration date on your strips. Check the meter. Check the amount of blood you put on there. Make sure it was used correctly, but maybe grab a different meter and check again. So use some common sense. Question it if you feel there's a problem. And this is what I said about the high and the low. If it's above 500 or below 15, it's going to not give you a reading. It's just going to say you've got a problem. Occasionally, mild hypothermia and or minor altered mental status is just as simple as giving them a sandwich and a drink. I've had lots of patients just go make them a sandwich, peanut butter and jelly with extra peanut butter, and a Coke with some sugar poured in it. If you've got a patient that you don't have access to food, maybe oral glucose is your option. They've got a history of diabetes, they have altered mental status, but not so altered they can't swallow. Give it to them and have them squeeze it in their mouth. It's just sugar paste. They can squeeze it in. It'll absorb into their system really quick because it's a liquid, and they should get the blood sugar to come right back up and change their mental status. If it doesn't change, transport them to the hospital, call ALS because you got something else going on. After you've given it, reassess. Every 5 minutes, you're going to reassess these patients. If they can't swallow, call ALS, transport them to the closest facility. Make sure you maintain the airway and treat everything as you find it. If you need ventilations or CPR, do it. If you're IV certified and it's in your protocols, this is where you could give 50% dextrose IV. So there's some benefits to being the IV certified EMT. I like to protect myself on figuring out if they can swallow and maintain their airway. I let them squeeze in their mouth. If they can squeeze it in their mouth, they can protect their airway. If they can't have the coordination to squeeze it into their own mouth, then they probably don't need to put it in. So let's compare hypo and hyperglycemia. Hypoglycemia is a fast onset, hyper is slow. Hypoglycemia is cold, clammy skin. Hyper is red, warm, and dry. Breathing. Hyperglycemia has acetone because they have all that extra sugar. Hypo means they have no extra sugar and you're not going to get the sweet smell. So patients with hyperglycemia breathe real deep and they have intense thirst. They want more water because they need to dilute what's in their bloodstreams. If you're not sure, give them glucose. It's not going to hurt them. It's going to make them just a little sweeter. If they're a hypoglycemia patient and you give them glucose, you're going to save their life. So we give it if we're not sure. Doing a glucometer helps us narrow it down real quick. All right, other causes of mental status. Seizure disorders. Something in the brain causes a seizure. It could be a injury, infection, disease process. Could be a congenital defect. Something brings rapid and uncontrolled movement, sensation, or behavior, which is called a seizure. Basic is partial seizure. It's just one part of the brain sends out signals that don't make sense to the muscles, and you have that uncontrolled convulsion. You could be fully conscious while you're doing this because it's the part of your brain that's not involved in keeping you alert. So maybe they have brief instances of unconsciousness. So it kind of depends on where it's coming from in the brain, what's going on with this. Generalized seizures, we have this full body seizure, comes from the entire brain. You'll have the tonic-clonic. Tonic is the tensioning, clonic is the shaking. Usually unresponsive, that increased motor activity. It says there's usually no warning, but if you have a highly trained seizure dog, the dog can tell you before you have your seizure. They sense the aura, the changes in your body, and can help you understand that you're going to have a seizure. It's really interesting to watch these dogs get their owner's attention, lay down, and protect their head while they're having the seizure. So the tonic-clonic have three phases. Tonic is it stiffens up for 30 seconds. Breathing may stop. You lose bladder and bowel control. The clonic is the rapid jerking. They foam with the mouth, it jerks around for a minute or two. They get cyanotic because they're not breathing adequately. And the final phase is postictal. Everything stops because the patient has used up so much energy. They're kind of slow to regain consciousness. They're drowsy. They could come out violent. Um, this is the one that's a little dangerous for you, but if a patient says they have a seizure or you find them in the postictal stage, and the bystanders say, "Hey, he was shaken," don't look at it as like, "Yeah, they really didn't have a seizure. They're just unresponsive." This is the phase we typically catch them in. Most common cause of seizures in adults is failure to take prescribed anti-seizure medicines. They've got a chronic condition. They just didn't take their meds as prescribed. So it's important to maintain those good medical regimens there, and then we can control the seizure activity. You can also have seizure activity from some type of brain injury, acute brain injuries, medication overdoses, other things. But the lack of medication is one of our causes there. With infants and young children, the main things that cause seizures are high fevers. Febrile seizure. Fever gets over 105, the kid can actually start going into the seizure activity. Other causes we've run into: hypoxia, stroke, traumatic brain injury, some type of trauma to the head. Other causes: toxins, hypoglycemia, brain tumor, congenital brain defects, infection, metabolic, or the best one I like is the idiopathic. It means we don't know. We're not sure what's caused it. They just had a seizure. Other things: a chronic condition with epilepsy, childhood diseases such as measles, mumps, rubella, eclampsia. This is a late term pregnancy seizure. Heat strokes. The body gets too hot and has a seizure. Or just onset of syncope. When a person passes out, they do have some shaking. A lot of times our cardiac arrests come in as a seizure because when the body loses that first ability to control itself, you have a seizure. Epilepsy is a lot of, uh, they throw a lot of things under epilepsy. It means that we know they have seizures. We know they're controlled with certain medications, but we're not sure exactly what the cause is. So they continually look for that. Uh, but as long as they can keep on their medication, things are good. When you're describing the seizure to the hospital, you need to be as descriptive as possible so they can narrow it down to where it came from. What were they doing when the seizure started? Did they know it was going to happen? Did they do anything to protect themselves before the seizure? What did they do during the seizure? What kind of shaking was it? Was it one body part? Was it all the body parts? Was there a loss of bladder or bowel control? How long did the seizure last, and what did the person do after the seizure? They don't have seizures and get up and go running. They have that postictal phase. If you get there and they're having a seizure, they are a high priority patient. We need to get them off the scene and to the hospital as quick as possible. Place them on the floor or the ground. We don't want them falling, so we're going to get them to a comfortable, safe position. If they have restrictive clothing on, loosen it. Get rid of the objects that may harm them. We had a gentleman that had a seizure at the Butterball plant, and he was the knife sharpener. He pushed around a cart with 200 sharp knives on it to replace knives for people during the workday, and he had a seizure and knocked the knife cart over on top of him. So it's important to get all the sharp objects away from people having seizures. Try to protect them from injury. Do not hold them down. We don't have to stick a wallet or a belt in their mouth because they're not going to swallow their tongue. We can use a bag valve mask on them while they're having an active seizure. If they have a vagus nerve stimulator, that is something that is not an EMT skill to use, but if the family has one and they need to use it, let them. That's a tool that's been given to family members to help stop seizures. After the convulsion's done, you want to protect the airway. If they're cyanotic, give them oxygen, get a pulse ox, find out what's going on. If they're not breathing, breathe for them. If they hurt themselves, treat it. I've seen people with broken limbs because of their seizure activity, so splint and transport. Like I said, don't put anything in their mouth. It'd be okay. You can suction around their teeth. You can suction while they're doing a seizure activity. Just don't put your finger in. If they have 2 or more seizures in a row, or one seizure that lasts more than 10 minutes, it's a condition we call status epilepticus. It is a medical emergency. We need to get them to the hospital as quick as possible and ask for ALS to meet us halfway or anytime they can catch up to us. There are medications they can give to the patient to stop the seizure activity, but we need to get them to someplace that can do that. As long as they're having seizures, the brain isn't getting good perfusion. The rest of the body's not getting good perfusion. So a partial seizure could be as little as tingling or stiffening of one body part or jerking. They may have the aura, they may not. They may not have any loss of consciousness. It could progress to a full tonic-clonic, but typically it's just a single body part. Complex partial seizure, they lose their mental status, lip smacking, fidgeting. They may appear to be drunk or on drugs. They're hard to work with. They no loss of consciousness, but they've lost their control of their mental capacity. You've got the generalized seizure. You got 2 types: petit mal or absent seizure. 10-second temporary loss of concentration or awareness. I know a lot of people that have these on a regular basis, or at least I think they do, because they just stare off into space. They don't have any body shaking or anything like that, but it's just that absence, or their brain locks up. Tonic-clonic, we've talked about that, the whole body shaking. People with epilepsy know what their condition is. They know how to take care of themselves. Once the seizure's over, they may feel comfortable staying by themselves or with a family member. Try not to let them stay by themselves. Don't let them drive. They shouldn't be doing that, but we should at least get them in the position where they can be taken care of. Next altered mental status we're going to worry about is stroke. It is a brain attack, or they're having the same thing that happens to the heart in the brain. So you can have an ischemic attack, which is where you get that clot or embolism that blocks the artery and has the infarction of the brain tissue. And it's just like a heart attack. The hemorrhagic stroke is where we have an aneurysm, causes bleeding of a blood vessel in the brain. It's people that have high blood pressure for a long time can have this. They have the weakening of the arteries and eventually rupture. Everybody has different symptoms to strokes because we don't know. I mean, every stroke is going to be in a different location of the brain, so they may have one-sided paralysis or weakness, difficulty speaking or complete inability to speak. They can't form complete sentences. They can't figure out what they want to say. Headache from severe bleeding. Deviation of the eyes. You look at them and one eye's off to one side. Inability to recognize parts of their own body. So they can't, when you say lift the left arm, they can't lift the left arm. They can't figure out what you're talking about. Could be aphasia. They can't communicate well. They have expressive aphasia. They know what they want to say, but they can't find the words. Or they have receptive aphasia. They can't understand you. So you're going to do some simple tests. We're not going to worry on the fine details of expressive or receptive aphasia. We're just going to note that they're having difficulties talking and what the difficulties are. You could have, kind of like we have angina pectoris, you could have a TIA, a transischemic attack. There's a narrowing of the blood vessels, or it's a small clot that busts loose, and they have the same symptoms as a stroke, but it resolves itself within 24 hours. The clot breaks up and they go back to normal life. The problem is this is a sign that they will have a stroke in the future if they don't get treatment. That means there's a narrowing of the arteries. Something's causing the TIA to happen. It just doesn't disappear. So we need to get them to go to a hospital or at least go to their doctor. Our tool for assessing whether they've got a stroke potential or not is called the Cincinnati Pre-Hospital Stroke Scale. You ask them to smile. Can they smile for you? If they can't smile or only half of their face goes up, then you know there's a potential for a stroke. Ask them to close their eyes and put their hands straight out in front of them and hold them for 10 seconds. If they can't lift both arms, lift them both straight in front of them. And if one drops, that's a sign that they have a potential for stroke. There's the lady holding her arms out, asking her to keep them in one place. The reason we close our eyes is to see if they've got spatial awareness of their arm. She doesn't have the ability to keep that arm up. She's positive for a stroke, or at least a stroke alert. Have them say, "You can't teach an old dog new tricks." If they can't say that phrase, they say the wrong words, they slur their speech, they can't say it at all, that's positive for a stroke. Notice there are no R's in this so that we can use it in Boston with no issues. This guy, you can tell he's got weakness on one side of his face. He's leaning his head that way, his tongue's in that side of the face, and he's drooling on that side. Other signs we're going to have confusion, dizziness, numbness, weakling, paralysis, usually one-sided, loss of bowel or bladder, impaired vision, high blood pressure, difficulty breathing, nausea, vomiting, possibility of seizures because of the areas impacted in the brain, unequal pupils. This is because you got one side of the brain that is not functioning right and not controlling how the iris on the pupil is working. Severe headache. If it's severe, it's usually a hemorrhagic stroke, but it could be both. Loss of vision or unconscious. What's important is the stroke chain of survival. It's that early recognition of the symptoms and getting them to the hospital. Had a relative that they waited 2 days before getting him to the hospital, and they drove him to the hospital with stroke-like symptoms, and he has permanent disabilities because of it. They didn't drive him because they were afraid of COVID. They didn't want him to get sick, so they let him stay there with stroke-like symptoms for 2 days. Many conditions mimic strokes, so that's why we want to get him to the hospital as quick as possible. UC Health is a comprehensive stroke center. Penrose, Maine is a primary stroke center. Both really good. The other thing we have in our area is the stroke mobile. We have the mobile stroke unit, which will bring a CAT scan to the side of the road and actually check the patient for ischemic versus hemorrhagic. If it's ischemic, they can do a quick assessment remotely with the doctor over a webcam and administer TPA to the patient to break up that stroke, the ischemic stroke, and get them back to normal. They just released a study in the New England Journal of Medicine about the mobile stroke unit, and the results were outstanding. So the quicker we get them into that stroke unit, the better off we are. If the patient's alert, keep them calm, give them oxygen if they need it. We don't want to keep giving them more oxygen if they don't, but if they need it, give it to them. If they're unresponsive, treat them like every other unresponsive patient. Maintain the airway, maintain the oxygen, and transport to the right hospital. It's very important we get them there within 3 hours of onset. Like I said, my relatives waited for 2 days and had permanent disability because of it. So within 3 hours, you can give TPA, the clot busting. If it's a hemorrhagic stroke, they can go in and do surgery right away. UC Health has a surgeon on duty 24/7, so they can do brain surgery right away. It's important for you to note the onset too. Dizziness and syncope, these can be just they passed out, or they're having some type of medical condition that caused a decrease in blood flow to the brain or oxygen level in the brain or something that caused the altered mental status. So it's important we get a really good history. We do a full assessment on these patients and try to figure out what's causing the problem to get us this point of dizziness and syncope. Syncope is a brief loss of consciousness with spontaneous recovery. If I see little bitty needles, like in sutures, my brain tells my body shut down. And so I will have a syncopal episode. I will get lightheaded, dizzy, I will get tunnel vision, and then I become unresponsive. It lasts maybe 30 seconds, and I start to regain consciousness. So that's a syncopal episode. It's a psychomotor or psychological response to things that scare me, little needles. It can be caused by cardiac dysrhythmias like bradycardia or tachycardia, infarcts, abnormal heart anatomy that valves are failing, and so you're getting backflow and not getting good perfusion. You could have a sensitive carotid sinus or the vagus nerve, which runs through the carotid sinus. A common occurrence, common enough that it's something you pay attention to. As you strain, if you have some level of constipation and you're sitting on the toilet and you try to push really hard, you can stimulate the vagus nerve, which will have a vasovagal sympathy or syncope. Your vagus nerve sends out the signal to activate the parasympathetic nervous system, and your heart rate drops down to next to nothing, and you pass out. That's one of the theories on how Elvis died. He had too many peanut butter and banana sandwiches and was a little stuffed up and pushed too hard and vagaled out. You could be low blood sugar, or a low blood volume, so hypovolemia, dehydration, bleeding, trauma. Could have syncope from it. Could have an inner ear problem. Hypoglycemia, stroke, seizures. So we need to be aware of all the causes and try to rule these out. Make sure we're not dealing with something that we don't know. Alcohol, drugs, some type of central nervous depressant, carbon monoxide poisoning. We'll talk more about that under the overdoses and poisoning chapter, but carbon monoxide, you typically have 3 patients. One is the person in the house, and the other 2 are the cops that went in to try to rescue them before fire gets there. Could be panic or anxiety attacks. Maybe they're scared of little needles. And sometimes they just pass out. We just don't know why. Our job is to identify life threats and treat those life threats. Try to get some history to help work through the process and figure out when did it start, how long did it last, were you standing up, sitting down, were you standing at attention too long, were you standing on a platform at a choir concert. See a lot of that in the high school choir performances. Are you on any medications? Do you have any other signs or symptoms? Anything happened that scared you? Did you get hurt when you fell down? Anybody witness anything? problem we run into is if they fall down and hurt themselves. Keep the patient on the floor. We don't want them falling over. I actually hit my head one time when I passed out in the ER when I was helping somebody stitch, and I ended up getting stitches myself and passed out again. So get them flat on the floor, loosen the clothing around the neck, take their ties off, take their necklaces off, give them oxygen, I'll call ALS just in case it's something we're not sure of, and then treat any injuries they have. So as with everything, if you have questions, comments, things you want to discuss, come to class with them and let's have a chat. Thanks and have a great day.